Hello guys, a very good evening. I hope I'm audible and visible. If so, just give me a thumbs up. I came a bit early because I was kind of not feeling well for the past week. So I thought I'll spend a little bit of more time with you guys and let's discuss few questions which were asked in the previous NEET PG exams. Fine. So I wanted to wear this T-shirt for the Mother's Day. This is something with Mary Bailey Academy, which is a campaign run by Unacademy. That is a very touching thing, personally to me, and I hope to most of you guys. So belated Happy Mother's Day wishes for everyone. Since I was not able to come live after that, I'm just saying it now, just belated one, right? So I hope your INICT exams went well, and I hope your results were not too shocking. And I'm sure that you must have done your best. And if by chance, if your results were not as expected as you wanted it to be, please don't get demotivated. You have a week, right? You have a week for the upcoming NEET exam. I just want you to. Can you hear me? Can you guys hear me? Am I audible? Am I audible? Okay, is that low? Fine. Okay, thank you, Priyanka. Fine. You will definitely do well in the upcoming NEET exam. The INICT marks are not going to be the main matter. What really matters is what you have done in the past 6 months to 8 months in your preparation, right? So, only one thing I want you to take from your exam is the mistakes you did. The mistakes you did, just keep them in mind and don't repeat them in the main exam as well. If you have been a little bit late to the exam hall, if you have made a few silly mistakes, if you have missed an easy question, please don't repeat that alone, and definitely you'll do well in the upcoming NEET exam, right? With that note, let's go on. So these are few things. I hope if you have subscribed to Unacademy, the 299 offer, if you have not done it and if you wish to do it, you can go ahead and do it. It will be for a month and it will be available only for a month. Don't subscribe 3-4 times so that it becomes 3-4 months. Everything is going to be only 1 month, fine. And the Unacademy Lite is for only test series if you want a push. And there are multiple courses if you're a plus subscriber. There are a good number of tests as well, free tests as well as paid tests. Please use the best of it, fine. Okay, UPSC CMS might be a good one for you post your NEET PG preparation. If you want to crack CMS examination, there's a very tiny short month course which might help you, fine. Okay, so let's start. So I'm just going to discuss a very basic PYQs here, not much, not many, something revolving around the topic. The questions will be easy. I want you guys to answer whatever comes to your mind, and I'll ask few leading questions and I want you guys to answer that as well, fine. That's all. Okay, so the first question, I'll kind of mute myself for the next 20-30 seconds. I want you to read the question and please go ahead and give the answer, fine. Let's start. Okay, guesses, answers, whatever comes to your mind, you can answer. Even if it's wrong, that's not a matter. It's a very simple question, right? Bernard-Solé syndrome. Okay, that's not what I expected. Fine. I'll ask you a leading question, something related to Bernard-Solé syndrome, then we'll go ahead and see what's happening. Okay, do you want to start with option A? Anyone else? You can keep it as A, B, C, D, or 1, 2, 3, 4, whatever is fine. D, B. Okay, fine. Okay, so answer a few leading questions. I'll definitely will easily arrive to an answer, right? What is the defect in Bernard-Solé syndrome? The glycoprotein, what is defective? What happens in Bernard-Solé syndrome? Then we look what will be the correct answer. The defect in Bernard-Solé syndrome, I'm sure most of you would have known, it's going to be in glycoprotein 1b9, right? It's going to be glycoprotein 1b9, which is going to be defective in Bernard-Solé syndrome, right? So the other glycoprotein is glycoprotein 2b3a, and that will be defective in Glanzmann's thrombasthenia, fine. So when you take any platelet for a matter, let's assume this is a platelet. This platelet has glycoprotein 1b9 on their surface, right? The ligand or the receptor to which glycoprotein 1b9 binds is to your endothelium. Endothelial's von Willebrand factor, right? Let's assume here there's an injury in this part. So in that part, my von Willebrand factor rises, and von Willebrand factor binds to my glycoprotein 1b9. This is what happens normally in case of a coagulation or a blood clot formation, fine? So this glycoprotein 1b9 is going to be defective in your Bernard-Solier syndrome, right? So what happens to an antibiotic called ristocetin? Ristocetin was introduced as an antibiotic. They stopped it because they were causing stroke and they were killing people, right? They promoted thrombus formation, right? So what happens is, when you add ristocetin to any normal person's blood, your or mine, what's going to happen is, this ristocetin will increase the clot formation if and only if both the components are present, right? If I have glycoprotein 1b9 as well as von Willebrand factor, ristocetin is like a fire. It initiates the clot formation if these two guys are present, right? So can I say a normal person like you and me will have clot formation when ristocetin is added to our plasma? Yes or no? It's a very simple question. Will there be a clot formation or not? Definitely there will be a clot formation, right? Okay. So in case of Bernard-Solier syndrome, as you guys said that, I'm not going to have this person. I'm not going to have glycoprotein 1b9. If glycoprotein 1b9 is not there, will ristocetin cause a clot formation? Yes or no? There's no glycoprotein 1b9 and we're going to name them as Bernard-Solier syndrome. Will there be a clot formation? There'll be no clot formation, right? It's a very simple test. So a patient with Bernard-Solier syndrome, the platelets will not aggregate in the presence of clot formation, right? That's in the presence of your ristocetin, right? So this statement is definitely true. Doesn't aggregate with ristocetin is true. Doesn't aggregate with ristocetin is true. So either it's going to be option A or B. We'll see what is the right answer. It will never aggregate with ristocetin. So option C and D are directly wrong, right? So I have either option A or option B, but option A has one more additional finding called collagen. Okay, so again we have to go back to the normal clot formation in order to understand this bit in depth. For a normal clot formation, the first step what we saw here was platelet addition. It's going to adhere. After addition, what happens is platelet releases lots of factors. The granules you must have read, right? What are the two types of granules? You guys definitely know the two types of platelet granules. Can you name them? You must have read about alpha granules and dense granules, right? So once this addition with von Willebrand factor and glycoprotein 1b9 happens, platelet will degranulate. Of that, I'll have epinephrine, I'll have your collagen, right? And I'll have ADP. So these three comes from the platelet granules, and these three ones are going to help in the next step, which is aggregation. Okay. So for aggregation, what glycoprotein do we require? I'm sure you guys know that. For the step of addition, I required my glycoprotein 1b9. What is the glycoprotein required for aggregation? That's your glycoprotein 2b3, right? I require glycoprotein 2b3 for an aggregation to happen, right? So can I say in a normal person where glycoprotein 1b9 is not present, if I add collagen, will all the platelet aggregate? Yes or no? They will aggregate, right? Because what I'm doing is, the entire purpose of this addition is to release the granule contents. But I am adding collagen in the test externally, mimicking the degranulation. So definitely platelet aggregation will happen if glycoprotein 2b3 is present, that's all. If glycoprotein 1b9 is absent, that doesn't matter for collagen. So when you add collagen to a person's plasma who's having Bernard-Solier syndrome, still there will be aggregation because collagen is actually a granule content released after addition process. By adding this externally, I am mimicking the natural process of having the addition, right? So definitely after my addition of collagen, if it is Bernard-Solier syndrome, it should aggregate. With collagen, it will aggregate. With ristocetin only, it will not aggregate, right? It's a very, very simple question. Bernard-Solier syndrome, the true statement is it doesn't aggregate with ristocetin. The option is answer B, fine? The way of aggregation, all of them are the base of diagnosis of all the platelet function abnormalities. Can any one of you name the test done to identify these changes? Like collagen or ADP or your epinephrine or your ristocetin. What is the test termed for? Because the INICT had lots of tests on genetics. What's the test which determines this? You must have heard that. Please remember this. This could come in an exam as well. investigation of choice for almost all platelet function disorder. It's not a thrombocytopenia, right? I'll come to that Swatrantha, right? It's not PFA, I'll come to that as well. It's not thromboelastography. For almost every platelet function disorder, the investigation of choice is going to be platelet aggregometry. Okay. In platelet aggregometry, which is a graphical representation of all these dynamics of clot formation, which is going to be useful for all the platelet function disorders. Thromboelastogram also was there in an question of AIMS or NICT, right? Thromboelastogram, the main purpose and the only purpose in general medicine practices during intraoperative procedures. The only advantage of thromboelastogram is it gives like immediate thing. For an PT or an APDT, for all these tests to happen, I need like half an hour to 1 hour time minimum, because I have to separate the serum and everything and plasma and do everything, right? But thromboelastogram, if the operation is going in the table, immediately the thromboelastogram most of the time will be done inside the OT only. They'll have a real-time thing. So intraoperative management dynamics of a coagulation, especially in surgeries like CTVS or neurosurgery, where it takes like 6-7 hours of surgery, that's the only place thromboelastogram is going to be useful. That's immediate, and obviously it's the best way for an intraoperative assessment, right? Coming to PFA 100. So PFA 100, it is kind of, when it came into the market, it was a huge thing saying that it can do everything. PFA 100 is like your CBC machine. You must have seen the report of CBC, right? Where I can give everything about MCV, MCG, everything. So PFA 100 is an automated platelet analyzer. It will give me lots of information. One, it's expensive. It's not being used much, because in routine practice I won't require that. Your platelet aggregometry is not as expensive as PFA 100 in the machine part, but PFA 100 can give me very reliable information about the platelet functions to some extent, and also to my platelet number, but it's completely automated. Since it's a bit expensive, I won't put them as investigation of choice. I'll still put in platelet aggregometry as an investigation of choice, right? But PFA 100 is definitely a good option. If both are there, personally I would prefer platelet aggregometry, because PFA 100 is not such an easy machine to have in most of the places, fine? Okay. Next question, I do want you guys to answer. This is a very, very simple question. So I'll mute myself for 30 seconds. Go ahead. Answer. You guys should answer this. It's a very, very simple one. Okay, Shreyansh has started with 2. Option 2 or option B. Anyone else wants to add to it? 2 Nidhi again. It's regarding a famous lymphoma, right? Burkitt's lymphoma. It's a very simple question, right? Great. It's 2. BCR-ABL, which disease do we see? Option A. It's again a classical finding seen in CML, right? Chromosome 8 and MYC is the same. MYC, c-MYC is there in the chromosome 8, so it cannot get translocated like that. Translocation 814 is a classical translocation in Burkitt's lymphoma. I hope all of you guys will know that. In peripheral smear, I won't see immature myeloblast in case of a Burkitt's lymphoma. If you look at the term, it's lymphoma, so obviously myeloblast will not be the answer, right? Option D is just to fill in the blanks. It's not the right answer, obviously, right? I am not a fan of mnemonics because I cannot create one, right? But these are few things which my seniors taught, so I'm just passing it on to you. Remember this if you have a difficulty in remembering the 8th chromosome. It's Burkitt. It's Burkitt's anyway, I'm saying it. So it's Burkitt's lymphoma, so you can remember that the chromosome 8 is where you have the MYC, proto-oncogene. So it's a classical, easiest way to remember Burkitt's lymphoma's chromosome, right? Almost every lymphoma involves the 14th chromosome, be it your mantle cell lymphoma, translocation 11-14, follicular translocation 14-18. 14th chromosome is the base for most of the lymphoid neoplasms, even for multiple myeloma. Translocation involving chromosome 14 is very, very important, because your chromosome 14 has something called an immunoglobulin heavy chain, IgH. If you remember microbiology, in an immunoglobulin, have you read something called as constant region and variable region? Have you come across that? You must have, right? And did you also, guys, I think you also had a question, something related to somatic hypermutation in this NICT. something related to that, right? So this immunoglobulin heavy chain has a variable region. The problem with this variable region, as the name says, it keeps on changing very fast. The DNA of this immunoglobulin heavy chain keeps on changing very, very fast. So when it changes, it's a mutation. I call this change a somatic hypermutation. So when it constantly changes, there's definitely chance that it can go and get translocated to another chromosome. That's why the chromosome 14 or immunoglobulin heavy chain is a common denominator for most of the lymphomas and most of the hematolymphoid malignancies, fine? Okay, I just want to read a little bit about Burkitt's lymphoma. Just take a little bit of time and understand about MYC, because MYC is something which is very, very interesting. And if you remember, you had an match the following this time in INACT for Burkitt's MYC and neuroblastoma's MYC, right? Because both of them had MYC translocation. One was CMYC and other was NMYC, right? The only thing actually I want you to remember regarding MYC is, can anyone help me in this? MYC is a proto-oncogene or a tumor suppressor gene? Albert Einstein, I'll leave the antibody structure to the microbiologist. There is a variable region. That's the only thing which I remember about the antibody structure. I can help you to diagnose myelomas, but the basics of immunology are still with microbiology. I'll leave it to them. I might be wrong, so only I'm just evading this question. Fine. Okay. Coming back to this, MYC. It's a proto-oncogene, right? Perfect. MYC is a proto-oncogene. So MYC has one important function. Remember this. This can also come in the MCQ. MYC kind of gives stemness to a cell. Okay. So I'll explain what a stemness to a cell means. So what all stem cells comes to your mind? If I say name a few stem cells in the body, can you name a few? I'll start with the easiest one, my bone marrow hematopoietic stem cell. Can you guys name any other stem cell which comes to your mind on the top of the head? Any stem cell. In liver, you have stem cell called as oval cells. In your bone, your skeletal muscle, you have something called as satellite cells, right? There are multiple stem cells in our body, right? Can I say any stem cell in my body has a capacity to replicate forever? It will keep on dividing again and again and again, right? That is given by MYC. So MYC kind of makes a cell not to stay in interface. It keeps on rotating in the cell cycle always. That's what MYC does. Because normally a cell divides, stays in interface, then enters cell cycle. Stays in interface, then enters cell cycle. MYC doesn't let that do it, right? MYC gives stemness to any cell. That's an important point. Do remember this. So this MYC is important for my normal body. My bone marrow stem cells will have MYC, the gene turned on. Your limbic stem cell, like Nidhi said, that also will have the MYC gene turned on. Any stem cell for that matter will have MYC positivity, right? So if MYC is a proto-oncogene and if it is mutated, so it's going to become gain of function mutation, right? Any proto-oncogenes will have gain of function mutation. So I'm going to have more function, which means it's going to act more like a stem cell. It will divide more faster. That's correct? Yes. So let's consider two types of MYC, like you guys know. CMYC, in which tumor do we see CMYC and which tumor do we see NMYC? I can write NMYC as MYCN or NMYC. CMYC is also MYCC or CMYC, fine. We see NMYC in neuroblastoma and you see CMYC in your Burkitt's lymphoma, right? These are two places where they are mutated, translocated or having a rearrangement, right? So when it's CMYC or NMYC translocation or rearrangement, I'm going to have gain of function mutation. So can I say both of these tumors grow very fast? Do they grow very fast or not? They grow extremely fast, right? Burkitt's lymphoma grows very fast. Neuroblastoma also grows very fast. Neuroblastoma can spread all over the body. It can grow very fast, even sometimes cross the midline as well, right? So there's a classical finding for both neuroblastoma and Burkitt's lymphoma. They grow very fast, right? Let's take neuroblastoma because Burkitt's is something which you've been reading for a long time, right? If I take neuroblastoma, if there's going to be an extremely high proliferation, if this is true, if my pathogenesis is true, can I say a cell which divides very fast, will they also die? Because there will be unnoticed error. It cannot retain. So death rate also will be more in the cell, right? If there is more proliferation, there will be more dead cells also. That's how it is. India has definitely more death rate compared to in USA or in Australia, where the population is less. More population, number of dead cells is going to be more, right? So now let's go back to a very basic thing which all of you guys know. What is the most common ion in an irreversibly injured cell or a dead cell? Most common ion. Is it sodium or calcium? Because these are the two ions which will confuse us always, right? In a dead cell or an irreversibly injured cell, is it sodium or calcium? It's a simple question. I want you guys to answer. Perfect. It's calcium, right? Okay, if it is calcium, can I say in the neuroblastoma, the NMIC, since there are lots and lots and lots of dead cells, more amount of calcium will accumulate? Yes. If that is true, can a neuroblastoma over the period of time, let's say 6 months to 1 year, can it develop dystrophic calcification? Because it keeps on accumulating, there's no one to remove them, so can it cause dystrophic calcification? They do cause dystrophic calcification, right? If you remember your pediatrics, almost every case of neuroblastoma, have you read that they have stippled calcification on an abdomen X-ray? That's due to my pathogenesis, right? So when I see an X-ray of a neuroblastoma, I will see stippled calcification. That's a very classical finding. Even in your MCQs, when you had stippled calcification on an X-ray in an infant, there's no other diagnosis. I don't even want an MRI. I can diagnose an X-ray because a suprarenal mass which can have a stippled calcification, more or less the diagnosis is neuroblastoma only. Because of NMIC gives stemness, more dead cells, calcium calcification, right? It's a very, very simple process. And reason of stippled, right? Because let's assume this big is a tumor. Can I say the dead cells, all the dead cells will not happen in a single place? I might have few dead cells here, few dead cells here, here, randomly, all through the tumor. If randomly I'm going to have dead cells, the calcium deposit also will be random. It looks stippled, right? Stippled is not uniform. It's here and there dots. That's why it has a stippled calcification X-ray, right? That's with NMIC neuroblastoma. So if MYC is so perfect, CMIC of Burkitt's lymphoma also should fit in, right? Look at CMIC. CMIC is also a very, very easy one. I'm sure you can relate them much easier. I'm just erasing this for a while, in the meantime. Okay, let's take CMIC and let's take your Burkitt's lymphoma, right? So if it's CMIC, again, it's going to be your proto-oncogene. I'm going to have gain of function mutation. The same routine, I'll have increase in the cell proliferation and I'll have increase in the dead cells as well. Okay. Now I have a slight change. In Burkitt's lymphoma, I will not have dystrophic calcification. I'll tell you the reason. You're going to tell me the reason, right? It's a lymph node. Let's assume it's a lymph node where the lymph node is being transformed to a Burkitt's lymphoma. Can I say a normal lymph node, even a normal lymph node, will have lots of macrophages or sinus histiocytes? Have you heard the term? They will, right? So if in Burkitt's lymphoma, if you have large amount of dead cells, can I say the macrophage will eat them and will destroy them and will make sure no excess load of calcification happens, right? Since it's a lymph node, all these dead cells will be consumed by macrophages. When they're consumed by macrophages, it's a macrophage. It'll keep on eating like as much as possible it'll eat, right? So let's say that I'm having a tumor cell. Let's put a box. This is the entire lymph node, which is fully filled with tumor cells, right? You know the color of tumor cells. Every tumor cell has a high NC ratio. If that is true, can I say a tumor or a malignancy in a microscope will be more bluish in color? Because high NC ratio, right? A microscopic tumor will be bluish in color. Let's say it's completely bluish in color like this. I'm having an extremely blue tumor because of the high NC ratio, lots of tumor cells, right? And it's consumed by macrophage. You're going to tell me the color of macrophage. All of you guys here, I want you to answer. It's a very, very simple and a basic thing. You must have used a prefix when you describe a macrophage. Let's say in atherosclerosis. What macrophage? Dash macrophage. What do you call them? In atherosclerosis, in atheroma, in heart attacks, in xanthomas, in your xanthogranulomatosis pyelonephritis, in your cholesterolosis, you had a prefix. What is a prefix? Dash macrophage. Starts with an F. Haven't you heard of something called as an foamy macrophage? Okay, perfect. I'll take whatever Albert Einstein said as well. Lipid-laden or a foamy macrophage, right? So now you are going to say me again. What is the color of foam or lipid in my light microscopy? What is the color of lipid in my light microscopy? We call them foam cell, Foamy macrophage, lipid-laden macrophage, absolutely right. Can I say the color of lipid is clear? Lipid has to be clear, right? Right, they're clear cells. So if the tumor has lots of macrophage here and there, I should have, sorry, just a second. If they have so much of macrophages, just give me a second. I should have here and there tiny macrophages, right? Will it look like a colorless white and a starry sky appearance? It should, right? The name starry sky appearance again is due to my pathogenesis. Stars in the sky. The stars are nothing but the lipid-laden foamy macrophage, which is clear, and the background sea of blue cells, which is being compared to the sky, is due to the high NC ratio of a cancer cell, right? Starry sky appearance is also due to MIC. My neuroblastoma is also due to MIC, fine. So I want you guys to read only this. When you go conceptually, it's an algorithm. The problem you guys face in any subject for that matter is you rely a little bit more on facts. Please erase them. Factual things are required at the bare minimum. I'm going to extrapolate, I'm going to go in depth, and I'm going to simplify it, break it into tiny concepts to remember it. Spend a little bit more time when you read, definitely you're going to reach heights. That's for sure, right? Now, why this is required for me is, at the end of the day, starry sky appearance is not important for me. Neither is my stipple calcification X-ray, because you can easily identify neuroblastoma. Apart from MCQs, these are not useful. I see you, all of you guys, as fellow doctors and colleagues, right? You're a student now, you'll definitely become a colleague in future. So for any practicing doctor, my only concern is patience. I'm not bothered about this MCQ. You also will not be bothered about this MCQ after maybe next a month, after you get your NEET exam result, you get into your PG. I hope you will, and best wishes for everyone for that. You'll not be worried about this MCQ. My only concern here is the patient. So if both of these are true, can I say both neuroblastoma as well as Burkitt's lymphoma will be extremely proliferating? So good prognosis or bad prognosis? Our only goal is patient. Good or bad prognosis? They should have a bad prognosis, isn't it? Because they spread faster, they grow faster, they undergo metastasis faster, so kind of a bad prognosis for me, fine? So when this has a bad prognosis, at the same time, understanding something helps me to think over a barrier. The barrier here is my high proliferation rate. If it proliferates a lot, you must have heard this. This is a fact you must have heard. Can anyone tell me what is the Ki67 in case of a Burkitt's lymphoma? That's an MCQ which all of you guys know. Ki67 in case of Burkitt's lymphoma, the percentage, you must have read that it's close to 100%, right? Ki67 stands for proliferation index, right? So proliferation index is close to 100%, which means every cell of Burkitt's lymphoma is always dividing. It's completely dividing always, right? Now let's use our knowledge of pharmacology into this. In pharmacology, you must have read about cancer chemotherapy cells, isn't it? If you remember the cancer chemotherapy cells, think and answer. A cancer chemotherapy cell will act on a resting cell or will act on a dividing cell? It's a very simple question. Will they act on a resting cell or a dividing cell? They obviously will act on a dividing cell, right? Now let's look at the beauty. I am having two basic sciences to make a beautiful medicine, right? It's a Burkitt's lymphoma where I have 100% of cells at any point of time which is multiplying. So what I do is, to this Burkitt's lymphoma, I give chemotherapy drugs. You will know the drugs better than me. I'm not going to go into the drugs part, neither into the treatment part, right? So when I'm going to add chemotherapy to this Burkitt's lymphoma, I can expect 100% cell death. Now tell me, good or bad? It's obviously looking good now, right? So Burkitt's lymphoma is extremely amenable to chemotherapy. It will melt with chemotherapy. That's what your medical oncology book says. It will really melt with chemotherapy, right? It's an extremely good thing. Again, my only problem here is I need an early diagnosis. If you diagnose it after metastasis, even my chemotherapy cannot help me. Early diagnosis is always the key for every cancer, right? This, an average MBBS student will know it, right? There's not a problem for me again. If you know this, and if you're seeing a patient, you go and treat the patient. the patient might have response, a decent response, right? I want you to be the best version of yourselves, right? If you're going to spend time in reading, spend it quality. Quality is more important than the quantity at any point of time. Read in depth. Now let's assume I gave chemotherapy, whatever regimen of chemotherapy is, to Burkitt's lymphoma. Have you seen an image of Burkitt's lymphoma? Everyone, once you Google Burkitt's lymphoma, you'll see an African kid with a big swelling in the jaw, right? All of you must have seen that image. It's such a big swelling. I give chemotherapy, the entire swelling dies. When entire swelling dies, the amount of cells which is dead there is huge. I'm going to have millions of cells which will die. Millions of cells at the same second it will die. That's a huge problem for me. We call them, you must have heard this as well, we call them a tumor lysis syndrome, right? I have tumor lysis syndrome, it completely lysis. I'm sure you must have read about tumor lysis syndrome, you know all the points. But I'm not going to ask any points, you are going to answer each and every point. Even if you don't comment, that doesn't matter, I want you to think through it, that's all. It's a normal cell. If a normal cell dies, it'll let go of few ions outside, it'll consume few things, right? The same thing is going to happen in tumor lysis syndrome, but at a magnitude in millions, right? What is the most common ion inside a cell? I'm sure you know that. If you answer few basic things from physiology, you can enumerate what happens in tumor lysis syndrome. The most common ion inside the cell, it is potassium, right? So I'm going to have all the potassium inside the cell will come outside, so it will result in hyperkalemia, isn't it? It will have hyperkalemia, right? Perfect. The second thing for me, if you remember your buffers, right? What are the common buffers which comes to your mind? The common buffers which comes to your mind: phosphate buffer, bicarbonate buffer, right? Protein is there, I'll ignore that for now, right? I have phosphate buffer and bicarbonate buffer. Will they also come outside? Yes, they will. So I'll have hyperphosphatemia. If phosphates comes outside, right, can it bind to calcium? Because phosphate is a negatively charged ion, and outside the cell I have lots of calcium, it will bind to calcium. Once it binds to calcium, what do you think will happen to calcium levels in the body? Will it reduce? Because phosphate binds to all of the calcium, and I'll have hypocalcemia, right? When you go algorithm wise, you might not have a mistake. Next one was bicarbonate. When bicarbonate goes outside, will I have acid base disturbances? Obviously, right? I'm going to have a little bit of more alkalosis. I'm just writing acid base disturbances, right? It will definitely happen. Last but not the least, I'm destroying DNA. I'm destroying DNA for millions of cells. When I destroy DNA for millions of cells, the breakdown product of purine, what is that? It's your uric acid, right? You'll have hyperuricemia. The best doctors is going to look at this. It's not about diagnosis of a cancer. Everyone can diagnose that, right? With the advent of lots of diagnostic things, biopsy, IHC, flow cytometry, MRI, PET scan, everyone can diagnose. The skill is in treatment. Again, everyone can give the drugs. The best doctor will anticipate this. When you give chemotherapy today, the next day all these will happen. So how I'm going to manage this? Routinely monitor. And one of the biggest problem for me here is hyperuricemia. See, kalemia, calcemia, acid-base disturbances, if I put the patient in ICU and maintain the electrolytes, that can be sorted to some extent. My biggest problem with hyperuricemia is not gout. Gouty arthritis is something which can be managed with NSAIDs. You guys know that, right? My biggest problem with hyperuricemia is they cause renal failure. That's a huge problem for me. They cause renal failure. If they cause renal failure, can I give the second cycle of chemotherapy? It destroys the kidney. I cannot, right? I cannot give second cycle of chemotherapy, because if I give second cycle of chemotherapy, they wanted to get excreted by the kidney, I won't have a trouble. If I stop giving second cycle of chemotherapy, can I say Burkitt's, whose proliferation rate is 100%, will have a relapse? It will have a relapse. That's a problem, right? So my main concern here is hyperuricemia. Like Anum said, other things can be maintained with hydration and IV fluids and titration of it, right? So that's the reason, if you remember your tumor lysis syndrome, have you read that you have to pre-treat the patient with a rasburicase? This comes in an MCQ. and allopurinol. I am not asking you fact. Questions never ask facts. Though it might look as a fact, there is something behind it, right? Though the HODs are there who are sitting there don't think much, but still their experience make them ask a fact with a predetermined notion that you have to remember it. Rasburicase is important, allopurinol is important because I should anticipate hypercalcemia before starting treatment. I have to give this, right? So this is what my textbook says. You must have read tumor lysis syndrome already. There are few classical tumors which will have tumor lysis syndrome. One is your Burkitt's lymphoma. Remember one more thing, ALL can also have a good amount of tumor lysis syndrome. Remember that as well, fine? But in a real life, it's not only these. Can I say any tumor which can have more number of cell death to chemotherapy, can they have tumor lysis syndrome? Is that possible? Or is it only Burkitt's and ALL? It's possible with every tumor, right? So any tumor with a very high Ki67 can have a tumor lysis syndrome, right? Just keep this in mind. This is not for an MCQ. This is for real life in future. You encounter any tumor where it says Ki67 more than 50%, right? Any tumor which says that my Ki67 of the patient tumor is more than 50%, please be cautious. It may cause tumor lysis syndrome. That's all. Please take care and give pre-treatment with allopurinol and rasburicase. It's not a toxic drug. If the electrolyte change doesn't happen, stop the rasburicase and allopurinol next time. If the electrolyte disturbance happens, remember this, right? Perfect. I want to take whatever Yogiraj said. He has kind of emphasized one of the important things there. I'm not sure if he emphasized that knowingly or unknowingly. You named ALL, hepatoblastoma, neuroblastoma. If you look at that, one thing which is common to two tumors is blastomas. When do you call something as blast? You must have read about myeloblast, lymphoblast. What does a blast mean? Blast means precursor or an immature cell. Good evening, Swati. Yes, blast is a precursor, right? Blast is a precursor or an immature cell. So can I say blast is a stem cell? Yes. So most of the tumors which have a starting point of a stem cell, that again comes back to my MIC, giving stemness to a cell, right? Anything which is involvement of stem cell or an immature cell, the precursors, has a risk of tumor lysis syndrome. It's not just my Burkitt's, right? It's just immature. Whenever more immaturity happens, it becomes very less differentiated. It becomes more anaplastic. It has a poor prognosis. All of them boils down to very basic terminology, right? Just remember the terminologies. You will extrapolate and you'll do very, very well in your exams, fine? Okay, let's go to the next one. Simple question. I'll mute myself for the next 30 seconds. Read the question carefully. I want you guys to comment. I am not going to ask you anything if you make a mistake, right? I'll never smile. I'll never laugh. I'll never make fun of you. Guarantee from my side. Okay, but I want you guys to comment. Answer? Okay, Shreyans has started with 2, Swati with factor 12. Anyone else wants to add to it? I want you guys to comment. It's fine if you make a mistake. Factor 11, okay. Anyone else? Factor 8, Mukesh, okay. Anyone else? Okay, let's see through the question. Let's see where we have made a mistake. I'll first read the question. Which of the following is associated with an elevation of APTT only and not with clinical bleeding, right? This is very important. If you have not read that negative phrase, not, right? I want you guys to read the question carefully again, right? Whoever answered factor 8 as the answer, can I say factor 8 will definitely have clinical bleeding? Will they have hemarthrosis? Factor 8 deficiency is hemophilia, right? Will hemophilia patient have hemarthrosis, your muscle hematoma, deep-seated bleeding? They will have, right? So definitely a patient with hemophilia will be presenting as an hemarthrosis, or something with a manifestation of bleeding, right? So factor 8 deficiency will not fit into this question because they do have clinical bleeding, right? Ruled out. Factor 10 deficiency also will have clinical bleeding. Factor 11 deficiency also will have bleeding, right? These are all bleeding and coagulation disorders. They will have bleeding for sure, right? But factor 12 deficiency will not have bleeding. That's very important, right? But still, factor 12 deficiency will have elevation of APDT. We have to see why, that's all, right? Because this, I'll tell you the importance of this question in future. Just give me some time, I'll tell you. You have to know this because it's not an MCQ, it's in clinical application. Once you remember this, you might not make few wrong decisions later on in your career, fine? Okay, you must have read this. All of us here, every time when you started from your Guide 10 or Canon or your Robbins pathology, you must have had this, right? Factor 7 here, extrinsic pathway. Factor 12, 11, 9, 8, both of them will join at 10, then 5, then brings your final fibrin clot, right? This is what you must have read, right? An extrinsic arm for coagulation pathway and an intrinsic arm of coagulation pathway. This is not how it happens inside the body. This is an in vitro. This is which happens in the lab. This is for lab test. This is not physiology. This is what happens in the lab. What happens inside the body? In vivo, what happens is, for an in vivo clot formation, the first starting point is always endothelial damage. Once my endothelial undergoes damage inside the body, it will activate factor 7, and I'm writing TF for tissue factor. This will activate factor 8, factor 7, factor 11, everything put together. In a real life, inside the body, for you and for me, factor 12 is not required. It's not needed at all. It's not a part of intrinsic pathway of coagulation. But it's a very important part for my extrinsic, which is the in vitro part of coagulation pathway, right? Okay, now let's have this and let's see how my question is correct. This entire thing is intrinsic pathway, right? What is the test which will tell me the intrinsic pathway is doing okay or not? There are two tests, PT and APDT. Which test do you think will help me in identifying the intrinsic pathway problem? It's APDT, right? And this person is prothrombin time for extrinsic pathway, right? So if I have a factor 12 defect, there's no factor 12 in a person, will it increase APDT? It will obviously elevate APDT, right? In a factor 12 deficiency, I'm going to have an elevated APDT. That's correct, because that's in one of the steps of the coagulation. But as I said that, factor 12 is not at all required for my in vivo coagulation. So if a patient has 0 factor 12, will it affect in vivo clot formation? Yes or no? It will not, and it should not, right? Okay. There'll be no problem inside the body, so there'll be no bleeding manifestations. The patient will not have any bleeding manifestation at all. Only the problem will be APD will be elevated, right? Okay. So this is what my question said. I am going back to the question once. Which of the following factor deficiency is associated with an elevation of APTT only and no clinical bleeding? Your answer is going to be factor 12 deficiency, right? I said that we are going to read everything from now on with an importance for a doctor in future, not with the notion of cracking NEET PG or INACT or whatever exam it is. You'll crack it for sure. I believe in you. So please, you also believe in yourself, fine? So why it is required for me in a real life? So why it's required for me in real life is I have to remember this. Let's assume that you're going to become a surgeon in future and you're going to do a patient's elective laparotomy. Let's assume, fine? I'll tell that Swati, just give me a second. You're doing an elective laparotomy for a person. For an elective laparotomy, which is a major surgery, you will require PT and APTT assays. It will be done because PT APTT assays become routine part of surgical evaluation, right? So during APTT doing that, and if you see an elevated APTT, don't jump and diagnose it as hemophilia. Please go and ask a history. If the patient is 45 years old or 50 years old or 30 years old with no history of bleeding till 30 years, it cannot be hemophilia. It will never be hemophilia, right? So if you have only a lab elevation without any clinical finding, please don't get swayed away by the lab report. It could be factor 12 deficiency. If it is factor 12 deficiency, you don't want to do anything for the surgery, you can go ahead with the surgery. If you're still worried, you can give some factor replacement and still do the surgery. Fine. Okay, now this is what he asked. That's a good question, right? So why do I have factor 12? I need to have something, right? If it is no use, I would have not discovered that, right? So what actually factor 12 does inside the body is, once a clot is formed, factor 12 is the person which plays one of the important role in fibrinolysis. It's involved in the coagulation pathway, but not in the formation of the clot. It's getting involved in the lysis of the clot. That's also involvement of the coagulation pathway, right? Now tell me, listen carefully and answer. You guys can answer for sure. If I'm going to have a factor 12 deficiency in a patient, will the patient have bleeding disorder or will the patient have paradoxical thrombus? You know the answer. Bleeding disorder or a paradoxical thrombus? It's a very simple question. They'll have paradoxical thrombus formation, right? Because normally it helps in the fibrinolysis. But if there is no lysis, I'm going to have a paradoxical thrombus formation, right? Perfect, right? So if you have in future a patient with factor 12 deficiency, the presenting feature will not be bleeding, it will be thrombotic episodes. Again, that's one more question for me, right? Having thrombotic episodes and it's a factor deficiency, I'm going to look for factor 12. That's how MCQs gets created, right? It's something out of the ordinary. If something's out of the ordinary, I want you to have more emphasis because you might miss them in the routine evaluation. Fine. Okay. This was a question from JIPMER. It's an interesting question. Answer randomly. You can get it correct. You might not get it correct. Fine. Okay. I'll mute myself for 30 seconds. Use Inky Pinky Ponky and answer. Okay. Answer. Yes, Giraj, you can ask it out. I'll definitely answer it out. I'll discuss this question as well by the meantime. We've got D, B, C. No one wants inflammation. You guys hate inflammation, is it? Okay, D again. B, okay. Fine. B and C, most probably, right? Okay. You must have, all of you must have, it is more a fun question. It's just this is there in Robbins, by the way. It's just to think out of the box, right? You must have heard about Darwin's theory, right? In Darwin's theory, Jogiraj, again, when it's coming to treatment, I am not going to go and put my beak there because I'll tell frankly, the last patient I treated was 10 years back. I'm good in diagnosis. You give me a biopsy of craniopharyngoma, I can diagnose with 100% confidence. But treatment part, I'm not taking it because I will not be 100% correct. And I'm not going to do anything which is not going to be 100% correct because it's your future, right? I'll take this question. Maybe I'll share it with Dilip or Dr. Saurabh Dikshit. Medicine or surgeon will be the best person to answer this doubt, right? So apologies, I will not be able to answer the doubt, fine? Okay, coming back to this question. It's Darwin's theory, right? So when you have a Darwin's theory, you must have read about Darwin's theory. You must have read during your school days. It's about survival of the fittest, right? That's what Darwin's theory said. The finches, the Galapagos finches, when Darwin went and researched a lot, what he said was the beak, right? The nose or the beak of the finch kept on changing. The only thing which was more stronger was able to survive because they were able to crack the nuts and they were having food. So he said that the beak changed because only when the beak changed, the finches survived. That was his theory, and that's where Darwin created the survival of the fittest theory, right? So this is about survival of the fittest, right? So now let's understand which of these four is going to be involved in the survival of fittest. It's cancer progression. It's purely cancer progression, right? Let's say, I'm sure you must have heard this. Have you heard about your sequence of mutations which happens in adenoma carcinoma sequence? Where have you heard about? Which cancer you heard about adenoma carcinoma sequence? Which cancers you have heard this term? Adenoma carcinoma sequence. It's very common in colon cancers, right? In colonic adenocarcinoma, you must have read about adenoma carcinoma sequence. That was asked in one of the innocent exam as well. Gastric also you have, colorectal predominantly. You have it for bladder, you have it for many cancers of late, right? It's adenoma carcinoma sequence. It started with a very tiny mutation, an APC, then RAS came, P53 came, telomerase came, or your SDH came, and it became very big. That's adenoma carcinoma sequence. So what it is said is, if I have this big a tumor, let's assume I have 8 clones, 8 group of cells. If my body is destroying this, destroyed 2 cells, the cancers realize them that's being destroyed and they get a new mutation. That's how it progresses from adenoma to a carcinoma. When the new mutation comes, my body cannot identify the cell because it's mutated already, right? So of these 6 cells which are present, let's assume a mutation came and my body struggled, my immunity struggled and destroyed 1. Then the next 5 or 4 arrives new mutation again. Again, there is a subclone. When this new mutation is identified and killed by my immune system, cancer realizes that and produces even more new mutation, right? So if you remember the image in Robbins for an adenoma carcinoma, it will start with a simple colonic polyp. It will become a growth carcinoma, and the last step will be metastasis, right? That is survival of the fittest. A stupid cancer cell learns from its mistakes. We should learn more from our mistakes, right? I'll kind of end the session on a positive note. Whatever score has come for your INICET, whatever rank you are, doesn't matter. You're still an MBBS doctor. You'll still do well. You can still manage a patient with a myocardial infarction. You can put a RISE tube. You can intubate a patient. You can do a PCR. Your skills, what you have developed and gained over the past 5 years, and versus exam. Exam is a test. Your skill is your universe, right? So please rely on your skill. Learn from your mistakes, whatever you have done in INICET, and definitely apply that to the NEET exam. If cancer can learn from Darwin's theory of evolution, Darwin is a human being, right? So we have to learn more, and you'll definitely score in a NEET exam, fine? Okay, Jabba Chaudhary, in general pathology, generally the questions come on the basics of cell injury, because the cell injury I don't want you to revise. The simple reason why I don't want you to revise is, most of you know about necrosis, apoptosis, hyperplasia, metaplasia and everything. If you want, give like 5 minutes glance, that's all. Read pyroptosis, necroptosis, little bit more in cell injury, and the intracellular accumulation. Inflammation again, give a glance on the steps, rolling adhesion diabetes. Read the disorders of inflammation like celiac Asher syndrome, NADP, joxis and all those things. Immunology, if you have covered in microbiology, ignore. If not, hypersensitive reactions, a glance. And read more, focus on GVHT, graft rejection, because that's a difficult part for most of you. And your immunofluorescence techniques in your autoimmune disorder, right? Cancer, neoplasia. Do spend good time for neoplasia. Even if it is not coming from general pathology, it will definitely have a role in any of the systemic pathologies, fine? Okay. So if you want to focus, necroptosis, pyroptosis, intracellular accumulation, inflammatory disorders, your graft rejections, GVHT, and cancers chapter as such. Genetics again, don't forget pedigree analysis and few of the normal things. Maybe give a quick revision on imprinting disorders, trinucleotide repeat diseases. That's a bit out of the context, fine. Okay, Yogiraj, first of all, for that INICET question, what you're asking, I would require that image. See, I'll give you a simple clue by which I will be able to diagnose an adenoma versus a polyp, right? I'll give you a very simple clue. You know the answer. I'm going to ask you a question and I'm going to derive the answer from that question, right? Adenoma versus a carcinoma, or a polyp versus a cancer. Which of these two do you think will have desmoplasia? A polyp or a cancer? Which should have desmoplasia? This will be applicable for every gross of polyp and a cancer. Can I say cancer should have desmoplasia? Obviously, yes. A polyp can also have a desmoplasia. Only cancer can have a desmoplasia, right? Cancer is invading. Only cancer can have desmoplasia. Desmoplasia is nothing but a fibrous growth, right? So if it is a fibrous growth, let's assume this is my gallbladder, the opened up gallbladder lumen. I'm having a polyp here. I'm having a polyp here. Let's assume I'm having a cancer here. If it's cancer, can I say the wall of the gallbladder should become thicker because of desmoplasia? That is generally the only clue required in the gross, because in a gross image I cannot identify anything than that. If it's a differential diagnosis of a polyp versus a cancer in an organ like gallbladder, it will be the cut open surface only. Please look at the wall. This will be applicable for your colon or your gastric, anything, right? So if you have a very thick wall, that is suggestive of a cancer, right? Again, I'm not saying it should always be a cancer. Or if you have a very ulcerated specimen, it looks like an ulceroproliferative specimen, then think of a cancer. Or if you remember your benign versus malignant gastric cancer, you must have heard this term, and heaped up margin. You have an ulcer and the margin is very protruding, a heaped up margin, think of a cancer, right? These are few gross terminologies which might suggest for me for a cancer. So since I have not seen the exact image, you will be the best person to be the judge of the question. Thick wall, bigger lesion, more proliferating, go for cancer. Thin wall, just polypoidal protrusion, it's a polyp, right? So I'll leave it for you for a conclusion, but this is how I differentiate in a gross between a polyp and a cancer, right? Any more doubts? Okay, if there are no more doubts, we'll call it a day. I'll do one thing. I hope if some of you guys are enrolled for the 299 pack of Unacademy, I wanted to start this last week. I was not doing well in health. So I'll do one thing. I have a 23 lesson course on NEET PG for Unacademy. I have done, Swati, you can search it back. I will create a WhatsApp group or in the Telegram group. I will just give you links of few topics which I feel is important. Just read them. I'll put MCQs based on that thing. Maybe every day 2 to 4 hours. If you can read, you can go ahead and do it. I hope in the last 1 week, at least 2 hours of pathology. If you're able to do it, I'll share the links. Just watch the video, fine. Nidhi, you can open the Unacademy app. I think it should pop up the offer, and if it's there, it should be there now, and you can enroll to it, fine. Yes, Swati, the solution for patho, the video will be there in the Unacademy YouTube channel. You can go ahead and have a look at it. It's not showing in the app. If you're using iOS, I think that might be a problem. Can you go to the website and enroll to it? Because few of the students commented they are not able to do it. I'm doing good, Chakravarti, thank you. Samir, entosis versus emperipolis. See, entosis is a mechanism of cell death where tumor cells die and eat with each other, right? Emperipolis is not a cell death. It's kind of like an ill-defined autophagy-like mechanism where when a cell has less nutrition, goes into another cell, takes rest and goes outside. That's what emperipolis means. You play in a playground, you take rest, go and play again. That's emperipolis. But entosis is one of the very older type of cell death. That's all. Right? There's a main difference between emperipolis and this. Thank you, Fat. Okay. Any other doubts? Okay, if there are no other doubts, I'll call it a day. See you soon. Till then, bye-bye. Keep your head up and always you'll win the game. Fine? Thank you for your time. Bye-bye.